Are we sliding?
What does that mean? That's new.
I don't know. I just made it up. Hey, did you know that camels ate cacti? I didn't
I think I
know
had seen
that.
that somewhere, but I've never like seen it with my eyes.
Yeah, I've been watching those videos. Pretty
Do they have
interesting.
like specific biology that makes them like, do they not care about the spikes?
I don't know. I'll look into
That's
it.
their primary source of water. Xander, how do you know that? All right, guys, welcome back. Strudel's review series. Here at the Hematology Review, the second part of the Hematology Review, where we're kind of going to go through these high yield cases and then sub points after them. We will be presenting it. We have Mike and we have Xander going to be replying either in the chat or verbally, kind of going back and forth and getting the most out of these questions. So we start here with our first case, a 3-year-old male presenting to the emergency department after a ground level fall onto his knees about an hour ago. Now he has these bilateral knee pain, swelling, with hematomas on exam and hemarthrosis on arthrocentesis, so bloody tap. His family history significant for easy bleeding, and bruising. So, Mike, what are you thinking of when we see a case like this, specifically with hemarthrosis?
So this is a pretty young boy. And yeah, I see in the chat. So I agree. So I was thinking hemophilia as well.
Yeah, very good. So, definitely something to think about, especially with this characteristic hemarthrosis. Our diagnosis is going to be hemophilia on most exams. What's our most common hemophilia, Mike, if you could give it?
I believe that would be hemophilia A.
Very nice. And that is obviously a factor 8 deficiency. High yield to know that. The pathophysiology behind hemophilia. So this is going to be impaired secondary hemostasis. Recall from our part one hematology review video, secondary hemostasis is the formation of the fibrin clot mediated by both the intrinsic and extrinsic coagulation cascade. So hemophilia A with a factor 8 deficiency, hemophilia B being a factor 9 deficiency, and hemophilia C being a factor 11 deficiency. All of those are going to be parts of the intrinsic cascade. So very high yield to remember that which ones are involved in which cascades. So clinical presentation, we already kind of mentioned this. Easy bruising, bleeding is very common. The formation of hematomas, you can have like that characteristic prolonged bleeding, oozing after teeth extraction, hematuria, epistaxis that lasts for too long. They're at risk for brain bleeding, but for exams, and I have it underlined there, very high yield to note that hemarthrosis is a presenting symptom, especially in these kids. Not many things cause hemarthrosis. It's kind of a unique presentation, so they kind of use it as a correlate with hemophilia. So, what kind of labs would we expect in these patients? Specifically, what would be prolonged? I already kind of mentioned it in passing. So, give me what you would think about the PTT, the PT, the bleeding time, and the platelet count.
So some base labs with, like a joint effusion. So you always want to be thinking about, potential cause of joint infusion like infection or inflammation or something like that. So CBC could show some anemia due to bleeding, but otherwise the ESR and CRP shouldn't be grossly elevated. So because this is a disorder with impaired secondary hemostasis in hemophilia, so you'd have a prolonged PTT, normal PT, and then normal platelet function and normal bleed.
Very good. So, like I had mentioned there, no matter what type of hemophilia you're dealing with, whether A, B, or C, those are all factor 8, 9, and 11 are all part of that intrinsic cascade that which we measure via the PTT rather than the PT. So the PT will be unaffected, and obviously that since this is secondary hemostasis, we are not going to see any changes with our bleeding time or our platelet count. So, kind of going into a quick offshoot, specifically that might be asked about hemophilia, will a hemophilia, like let's say this patient with hemophilia A, will it correct with mixing, with a mixing study, meaning taking somebody else's serum and mixing that with the patients and then seeing if the PTT normalizes? Would you expect it to normalize or not?
Yeah, I would expect the PTT to normalize with mixing study.
Perfect. Yeah. So this is going to correct with mixing specifically because if you just think about it in the simplest sense, they are missing a factor, and by putting somebody else's serum with it, you're going to give that back to them. So their PTT is going to correct with mixing. So let's kind of talk about treatment of hemophilia. So there's kind of two schools of thought whether this disease is severe in nature or whether it's pretty mild. So if it's kind of give me an idea what you're thinking, Mike, when it comes down to severe hemophilia, maybe with like really symptomatic bleeding, versus mild, where they're really maybe they're dealing with some nosebleeds or some bleeding when they brush their teeth, but it's not causing them any distress.
Yeah, this is a tough one. So, any ideas in the chat, Xander? But
Severe
what
versus mild hemophilia treatment.
Yeah, what I think is so for severe hemophilia treatment, then you use the recombinant factor. So factor 8 for hemophilia A, and factor 9 for hemophilia B, or yeah, hemophilia B. And then uh, in the chat, Xander has, and I agree, for mild hemophilia, you can use desmopressin. And I believe the way that works is by increasing von Willebrand factor release. And by increasing that, then you'll be able to stabilize factor 8.
Absolutely. So very good to know. If it is severe, if they're super symptomatic, you're going to want to replace that factor right away, whatever that be, whether it's A, B, or C. And mild disease can be treated with desmopressin or DDAVP, basically synthetic ADH. It increases von Willebrand factor release from those Weeble Palade bodies, which we mentioned in part one of our hematology review. And the interesting thing about von Willebrand factor is it also stabilizes factor 8. So the factor 8 that these patients do have will be will be amplified, their function will be stabilized, and you can kind of get the most out of the factor 8 that they have. So this would only be for mild hemophilia A, as factor 8 is the deficient factor there. So you can't use desmopressin for hemophilia B or C. So now, kind of moving into this kind of another offshoot question, kind of similar to the mixing study. So distinguishing an acquired hemophilia versus a genetic or a congenital hemophilia. So I'm going to kind of just go into this one. Obviously, an acquired form is going to appear later in life. That's what acquired means. But specifically, when we see this is due to autoantibody formation against the replaced factor. So these are patients who are going to be given transfusions or of the factor that they're deficient in, and eventually their body's going to develop antibodies against that factor, which we will refer to as an inhibitor. So if you have that, what's very important to know is that if you have an acquired hemophilia with an acquired inhibitor, your mixing study is not going to correct anymore. And that's because even though you're replacing that factor in the patient's serum, you're also going to have these autoantibodies that are going to prevent the function of the factor. So if you see somebody history of hemophilia and they've required several factor 8 transfusions, let's say it was hemophilia A, and now suddenly they are continuing to bleed despite giving factor 8, and you do the mixing study and it doesn't correct, you should be suspecting that these patients have developed an autoantibody against factor 8 or an acquired inhibitor that's causing that. So, kind of a bonus question. I've seen this tested a few times. Let's say this patient, this is not the last time that he has hemarthrosis after some joint trauma. So, repeated hemarthrosis, what could we expect to see as kind of a side effect of that, Mike?
So I think this would be a type of arthritis, mostly due to like hemosiderin deposits. And yeah, in the chat we see erosions in the bone. So mostly I think in the articular surface, due to hemosiderin deposit, which can accelerate essentially arthritis.
Perfect. Yeah. So these people, since you're going to have old blood that basically accumulates as hemosiderin, and you're going to have accelerated joint breakdown in those patients. So good kind of little tidbit to know. So moving into our next case, 25-year-old woman. She has 2 days of a red swollen calf. She's never had a similar episode in the past. Doesn't have any shortness of breath. On exam, you appreciate that she has tenderness to palpation of the right lower extremity. She has some pain with dorsiflexion of the right foot. What's your next step in management and your likely diagnosis? So kind of going for a double hitter there, Mike.
So this sounds like the classic presentation for a DVT, especially with the home positive Homan sign, which is the dorsiflexion of the right foot. So next step in management would be at this point probably to confirm the diagnosis with ultrasound, and the likely diagnosis would be DVT.
Very nice. So, yeah, first step we're going to go for is the ultrasound DVT VTE. I did see in the chat there was a little bit of speculation like, is this possibly, could it be acute limb ischemia? if it was acute limb ischemia, what kind of exam finding would I have given you on the exam? Like instead of the tenderness on palpation, pain with dorsiflexion, what might I give you on exam that would tell you like, oh, maybe this limb is ischemic? And there it is in the chat. Yeah. So your five P's mainly on exams are going to say maybe the pulses are not palpable. It's going to be pale. It's going to be cold, all that stuff. So very good to differentiate between DVT and acute limb ischemia because obviously similar kind of pathology with there being something in the blood vessels, but very different presentations and very different managements as well. So good to keep that in mind. So let's say we think that this is an unprovoked DVT. So she didn't go on a big flight. She didn't wasn't on a long car ride. She's not on oral contraceptives or hormone therapy such as that makes her more predisposed to clots. What kind of genetic things would we suspect? What's the most common, at least? We'll start there.
The most common, this is a surprisingly high yield fact, I think, is that factor five Leiden is the most common genetic predisposition for a hypercoagulability. And I think about 5% of the Caucasian population has this gene, and it's an autosomal dominant um, gene.
Yeah, very good. So just kind of the whole list there. So you have factor five Leiden, that's the most common. Also kind of high yield to know its pathophysiology. So specifically with factor five Leiden, these people have a factor five that is mutated to the point where it does not respond to activated protein C. And usually activated protein C breaks down factor five. So if you can't break down factor five, you're pro thrombotic or you're going to have increased tendency to clot. So that's kind of the reasoning behind that disorder. You can also have a prothrombin 20210A mutation, protein C and S deficiency, and then antithrombin deficiency as well. So those are your genetics. Like Mike said, factor five is very, very commonly tested. But would you obtain genetic testing at this time, Mike? What do you think? It's kind of a coin flip. Two answers.
No.
Yeah. So we've kind of mentioned this before in our past strudel reviews. If there's an opportunity for you to be more conservative, think really long and hard before you go after something expensive like genetic testing. So, as this is the first instance of a venous thrombus, it's not a life-threatening one where it's massive by any means. They don't tell you that it's really huge or it's causing a really severe pulmonary embolism as well. And there's not like multiple. Um, you don't really have to go after genetic testing at this time. Now, if she was to have another one and it was now recurrent, that might be a very good reason to go after genetics. Or if she has a very strong family history, like Mike said, factor five is autosomal dominant. So usually these people do have positive family history. But in this case, since it is the first time, it's not going to affect the management. We're going to treat it as an unprovoked, we're going to treat it as a DVT, just normally. So other causes of hypercoagulability, let's say I kind of what I'm going for here. What about one that's specifically associated with findings of lupus? So maybe this patient will have like a little bit of a malar rash, she'll have some non-specific arthralgias, she'll maybe have even some signs of like pancytopenia, things like that. So what do you think of when I'm talking about that stuff?
Is their PTT elevated?
I don't know, is it?
Well, if it's what I think it is, which would likely be antiphospholipid syndrome, interestingly, on the lab findings, you'll actually have a paradoxically elevated PTT. It's just an artifact of how the lab test is done, but they're actually going to be hypercoagulable.
Perfect. Yeah, so I was going for antiphospholipids. So the paradoxical elevation in the PTT is very high yield to kind of note because they might give that to you in the lab findings in an exam question. But antiphospholipid syndrome, especially with its association with lupus, is very high yield, and it's specifically in test questions and in real life as well. But in test questions, especially, what's your like textbook phrase or finding in somebody's history that would steer you towards a diagnosis of antiphospholipid syndrome?
Essentially, recurrent spontaneous abortions and then DVTs as well.
Perfect. Yeah. So recurrent pregnancy loss, this is going to be due to placental thrombosis. They might give you that these people are like G5, P0, or something like that. Um, they will make it pretty obvious that they've had the recurrent pregnancy losses. A lot of times these patients do present in pregnancy, and if that is the case, and they have this history of recurrent pregnancy loss, what do we do to prevent another recurrent pregnancy loss? How do we treat this in pregnancy?
I believe that would be with like heparin or low weight molecular heparin.
Yep, very good. So if you remember the mnemonic, like keep the baby like happy or happy with heparin, In pregnancy, you want to use heparin derivatives, and Lovenox is usually the preferred one there, rather than anything like warfarin or even Doax right now. I'm sure eventually maybe they'll be studied in pregnancy, but I haven't, to my knowledge, there's no indications for Doax in pregnancy yet. So for now, Lovenox is kind of your mainstay in pregnancy.
Yeah, and
So then next,
um
it's toxic.
warfarin is the to be avoided in pregnancy. It's
Correct.
teratogenic, I believe.
Yep, it is. Very well. So we have a 38-year-old here. They're previously healthy female, presenting with epistaxis for about a day. Also has this history of IV drug use. She has blood in her nares, and petechiae are visible distal to the blood pressure cuff. Her platelet count's like 28,000. What do you kind of think of? So there's a lot of kind of things in this question that kind of seem unrelated, but there's a disorder that kind of combines her historical risk factors and her thrombocytopenia. So what do you think of?
So this sounds like because it's really isolated thrombocytopenia, especially in the setting of IV drug use. I don't see any prior history of like a upper respiratory infection, but the IV drug use may be related to some kind of viral infection. So most likely ITP, immune thrombocytopenia, but I think this is all actually a diagnosis of exclusion. So we would definitely want to rule out other causes of thrombocytopenia, but I think that's the direction that we're going in for with this vignette.
Yep, absolutely. So for the case of a test vignette, immune thrombocytopenia is kind of where I'm going with this. Now, Mike is absolutely right. This is a diagnosis of exclusion. So you're going to work them up to find other causes, potentially reversible causes of thrombocytopenia. But if nothing comes up and you have this history with IV drug use, ITP seems like kind of your best bet. Pathophysiology behind ITP is very high yield, and I'll kind of just go over to it. So this is acquired immune-mediated destruction of platelets. Specifically, we're going to be talking about IgG antibodies that are formed against GP2B3A. If you remember, that's one of those receptors that are found on the surfaces of platelets. And obviously, primary is going to be idiopathic in nature. And then there are secondary causes. Cancer, infections, autoimmune conditions can all cause secondary immune thrombocytopenia. So just keeping in mind also like other autoimmune conditions, kind of a high yield point in any exam. If they have one autoimmune disease, they're at risk for others. So if you see someone with lupus, it's not out of the picture that they have ITP as well, just secondary to another autoimmune condition. So the clinical presentation for ITP is largely variable. You can be completely asymptomatic. They just find thrombocytopenia on routine labs. Maybe they have mild mucosal bleeding, like this lady that's having epistaxis that's kind of persistent. Then you can get into even like the more severe findings where you actually do have the extravasated blood of petechial rashes or purpura that you could see on exam. So really is a pretty decent range of presentations. Obviously, your lab finding is mostly going to be centered around that thrombocytopenia without much else going on. And your treatment is kind of multifaceted in that it depends on not only the status of the patient, but also the general platelet count. So we'll kind of go through this one at a time. So Mike, tell me what you're thinking. This patient has platelets, let's say greater than 30,000, and they're asymptomatic. So they're not necessarily there's no symptoms or signs of bleeding. They haven't noticed any hematuria, no bright red blood per rectum, nothing like that, no melena. What do you want to do?
So if their platelets are greater than 30,000 and they're asymptomatic, then I believe we can just continue to monitor and just have conservative measures. No need for any steroids at this point. I was actually reading about this today.
Yeah, so being conservative once again on these exams, very high yield to know when to not do anything. This would be one of those times. So now, in contrast, let's say you're more like our patient. So platelets are less than 30,000 or they're bleeding. So whether that be like a super symptomatic bleed or just like this person, an epistaxis that can last a whole day can end up causing problems that you could see as some anemia. So what would you do then? So platelets less than 30,000 or and bleeding.
Then I'd probably start with IV steroids, probably like a prednisone or methylprednisone. But I know there are other options for immune suppression like IVIG.
Nice, yeah. So let's say steroids and IVIG don't cut it and it's persistent. What do you do for refractory disease?
Then you can, well, if a patient has refractory ITP, not responding to any any of the medical management, then you can consider a splenectomy.
Good. So it's always nice to know the reasons for splenectomy because they do like setting patients up for splenectomy so they can test things such as needing like different vaccinations against encapsulated organisms and things like that. And like I had kind of mentioned, or like Mike mentioned, sorry, corticosteroids or IVIG, both are decent methods of treating this. I believe corticosteroids are the most commonly tested. IVIG is kind of a backup to them. And children with ITP specifically respond well to steroids. And that's a running theme. There are a lot of conditions where children tend to respond a little bit better than adults. And I kind of had mentioned this in passing before. So let's say you do all the studies for thrombocytopenia and you don't find a primary cause or any other reversible secondary cause and you think it's ITP based on your diagnosis of exclusion, what other things should you test for that are associated with ITP?
Yeah, so especially in this patient, other things that can be associated with ITP are viral infection. So in this patient, maybe HIV and hepatitis screening. Otherwise, uh, ITP can also be paraneoplastic, so making sure they're up to date on their cancer screening.
Perfect. Yeah, so HIV and hepatitis are very commonly tested in this scenario because you should have a very low threshold to suspect and to test. So this patient had a history of IV drug use. If you had a history of like multiple sexual partners, things like that that make you think maybe HIV or hepatitis could be in play, you should have a very low threshold of testing for those things because if we find them and find them early, there's a good chance that we can treat them and save a lot of complications for the patient. Along with that, cancer screening, especially age appropriate cancer screening. So looking at, are they up to date on their colonoscopy? Are they in the age bracket for colonoscopy or mammography? Whatever the case is, it might be worth checking those things out as well. So kind of moving into the next case study here. So we have a 47-year-old male. He's got fever, altered mental status, and a lower extremity rash, very specific for all my dermatology friends. He also has a history of IV drug use, and he has petechiae on his lower extremities, distal to the blood pressure cuff, and labs showing a hemoglobin of 8, platelet count of 20,000, and a creatinine of 2.8. So we do end up getting a little bit more specific for the dermatologists out there. We end up classifying as petechial in nature. But tell me what you're thinking about this patient.
So the lower extremity rash is, is petechiae, which are those pinpoint, essentially extravasated red blood cells. So these will not blanch on diascopy, which is when you like basically push on them or with a glass slide. So either way, fancy way of saying usually this indicates either thrombocytopenia or vasculitis. We know this patient has thrombocytopenia with a platelet count of 20,000. So they also have anemia with a hemoglobin of 8 and then elevated creatinine and altered mental status. So these all point me most likely to TTP, which is um, thrombotic thrombocytopenic purpura.
Perfect. Yeah, so especially drawing um, emphasis to the altered mental status or the neurologic symptoms and the AKI in the setting of anemia and thrombocytopenia. So the pathophysiology, and this is pretty high yield to know, this is an autoimmune destruction of Adams 13. And Adams 13 is a protease that normally breaks down von Willebrand factor multimers. So von Willebrand factor that sticks out from the endothelial surface now is able to kind of form these long multiples that stretch further out into the bloodstream and can therefore cause shearing forces on the red blood cells and the platelets, leading to a microangiopathic hemolytic anemia or a MAHA type picture. So that's why you would expect this kind of both anemia and thrombocytopenia, specifically because of the mechanical shearing forces. So good to know that. And the clinical presentation, we had already kind of mentioned it. There is a mnemonic for this, and if you look at the first letters of these symptoms, you'll kind of be able to interpret it. I'm not going to go off saying it, but you have fever, which is important, anemia, specifically in the pattern of a MAHA or microangiopathic, thrombocytopenia as well. They're going to have renal failure. And then the big one to note is neurologic abnormalities. So whether that's confusion, seizure, numbness and tingling, but this is kind of your big um, fork in the road when it comes to TTP versus HUS. So good to know that stuff. Definitely put emphasis on the neurologic abnormalities and the MAHA. If you can identify those two, you can kind of close in on TTP. So, what kind of labs would you expect to kind of find? So, we've already talked about the anemia, the thrombocytopenia, the AKI. So, your creatinine will be a little bit high. Since they're hemolyzing, what kind of lab findings would you expect in hemolysis?
So with hemolysis, you'd have those hemolysis labs. So elevated LDH, you're going to want to get CBC with a smear where a pathologist actually looks at the slide and they might be able to see schistocytes or helmet cells. You'll have low haptoglobin and then increased total bilirubin.
Very good. Yeah. So these classic labs of hemolysis are very important to know. Increased LDH, low haptoglobin, increased bili. You'll have normal PT and PTT, normal fibrinogen, which kind of rules out a more DIC type picture. And there's a question in the chat as well. Increasing of the bleeding time. If they have thrombocytopenia, yeah, you could see an increased bleeding time as well. Um, Bleeding time in general is very rarely tested in clinical practice, but if they want to give you one of those nice USMLE arrow type questions, the bleeding time you could expect with thrombocytopenia to be elevated. So good to know that as well. So how do we treat? What do we do?
HES, I believe, is notoriously difficult to treat, but first line treatment typically involves like plasma exchange or plasmapheresis, and then steroids are not quite as helpful, but can be considered. And then you want to avoid giving platelet infusion or transfusion just because that's not really treating the underlying process, and it's just going to contribute to the amount of shearing.
Very good. Yeah. So plasma exchange, steroids, splenectomy, and the platelet transfusion, like you mentioned, you're just pouring more fuel on the fire. They're just going to get sheared along with the rest of them and cause more problems. So good high yield case of TTP to know. So now you have a 7-year-old female. She's had several days of bloody diarrhea. Other members of the school she attends have also had bloody diarrhea. She's irritable, she's lethargic. Looks like she might have a little bit of jaundice, and she has petechiae on her upper extremities. Her creatinine's high as well at 3.0, platelets a little bit low at 38,000. Her hemoglobin is 8. A peripheral blood smear shows schistocytes, which is another sign of hemolytic anemia. So this case, obviously right next to TTP where it should be, a very high yield differential. And what is that, Mike?
So, like you said, kind of the relative of TTP and often tested together. And I see in the chat HUS often from Shigella or EHEC, which I agree.
Yep, very nice. So we're thinking here of HUS or hemolytic uremia syndrome. The pathophysiology is also somewhat high yield to know, and that's that this is a toxin mediated process. So because of the toxin, whether that be Shiga toxin from Shigella or Shiga toxin producing E. coli or EHEC, you're going to have the formation of microthrombi, and they're going to occlude the microvasculature and cause a very similar MAHA type picture. And that's just secondary to these damage of the endothelial cells. You're going to have kind of a cytokine storm type picture. The red blood cells are going to be destroyed as they pass these platelet microthrombi and kind of get sheared off that way, rather than the von Willebrand multimers seen in TTP. So you're going to have very similar things, but as you can notice in the case vignette, there is no altered mental status. Now, she is a little bit lethargic and irritable, but that's kind of the way that examiners like to test kids being sick. So if you see those kinds of things, that's just them saying kind of non-specifically sick. So if she was seizing or was having some, numbness, tingling, or really altered in nature and confused, then you might kind of steer more towards TTP. So the clinical presentation is kind of in a stepwise format. So first you're going to see the thrombocytopenia, then you're going to have this formation of a non-immune microangiopathic hemolytic anemia, and then acute renal failure kind of rounding out the presentation. So that would be the hemolytic uremic syndrome. Your symptoms can be pretty variable as well. A lot of times they're going to focus around the centers of the primary illness. So that's your abdominal pain, bloody diarrhea, nausea, vomiting. And then you can also see, like we had mentioned in this case, the hemolysis type symptom or sign of jaundice and pallor as well with some fatigue. So good to know that that's kind of the not only stepwise, but also like the emphasis on the GI symptoms to really draw you to HUS rather than TTP. So we've already kind of mentioned this. This is not due to Adams 13 deficiency. So if you were, and this is a possible test, you can do plasma levels of Adams 13. So you would have a normal Adams 13 in HUS rather than decreased in TTP. And usually you will not have a focal neurological deficit or very clear alteration, seizures, thing like that. So what would we expect to see on our labs, Mike? What would we expect here in our HUS patient?
So again, you would see some labs consistent with hemolysis. So that would be your low haptoglobin elevated, um, LDH, elevated T-billy, things like that. And then you'd see thrombocytopenia and anemia as well, normocytic anemia.
Very nice. Yeah, so very similar lab profile to TTP. So that's why they really want you to be able to differentiate based on presentation and risk factors. So your peripheral smear, we had already mentioned the schistocytes or the helmet cells. And then treatment, Mike, what do we do for this patient? And what do we not do for this patient?
So treatment for HUS is typically supportive, but the important high yield fact to know is that we want to avoid steroids in these patients because they essentially will cause lysis of the bacteria, but that will actually cause them to release their endotoxin into the bloodstream, which will cause worsening of the HUS.
Very good. Now, you did say steroids, not antibiotics. So, we're going to have to deduct a point from you there, Mike. But yes, so in general, we're going to treat supportively. We're going to promote renal perfusion, IV fluids, things like that. And we're not going to give antibiotics. And that is exactly like Mike said. If we kill the cells, we'll release more toxin, and this is a toxin mediated process. So, it's just going to make things worse. So, we would not want to do that.
I
Very good.
meant to say antibiotics.
I know you did. Would you tell it to the judge? So, we have a 38-year-old male. Now, he's admitted to the ICU. He has sepsis. He ends up developing a DVT. He has a petechial rash. He's having like oozing or bleeding at his IV sites. His labs show anemia, thrombocytopenia. His PT and PTT are elevated. He has low fibrinogen, elevated D dimer, increased LDH, bilirubin, and his smear shows schistocytes. So basically, you have a giant mess. And what is this, Mike?
This concerns me for DIC, which especially in critically ill patients.
Very good. Yeah. So DIC is what we're looking at. Especially these labs that I have shown there is very, very high yield because, and we'll go into it in a little bit, they love to test this with arrow questions. So knowing that your PT/PTT is going to be prolonged, fibrinogen's low, D-dimer's high, you're going to have hemolysis labs as well. So very good to know that. So this is DIC, especially in the setting of a critically ill patient. That should really steer you into this diagnosis. The oozing from the IV sites is also pretty high yield for DIC. Pathophysiology, this is a diffuse kind of syndrome of coagulation resulting in consumption of coagulation factors. So your buzzword being consumptive coagulopathy. So this is where, because of all the inflammatory mediators flying around, the body is both making and destroying clots in rapid fashion. So not only are they at risk for bleeding, like this patient, they're have a petechial rash, they're bleeding at their IV sites, but they're also hypercoagulable in nature. So knowing that it can go both ways is very high yield to know and to understand clinically why we're kind of in a bind when we see a patient with DIC. There's really no way, no good way out. So the presentation is going to be largely dependent on the abnormality underlying it. So they're going to have severe illness usually in their history. Pregnancy is also tested with like amniotic fluid emboli and things like that. It can be a weird presentation of it. Trauma that can be severe, and it can also kind of occur later on, like when they get in the ICU and they seem to be stable, this can happen. They might have transfusions in their history, but it is this mixed overall picture of bleeding and clotting. So we already mentioned the labs, and they are very high yield. I'm going to throw them up on the screen. We're not going to go over them again, um, but knowing this combination of lab values is very high yield for exams. And so, how do we treat DIC, Mike? I already kind of mentioned it really puts us in a bind.
Yeah, I usually kind of supportive treatment and then really want to look into treating the underlying cause. Yep, and I see that in the
Perfect. Yeah. Addressing the underlying cause and supportive care. These patients, obviously they have a DVT, but you're not going to give them a blood thinner because they're also bleeding, and they're bleeding, but you don't want to transfuse them and give them clotting factors because they also have a clot. So it makes it very difficult to determine where you would go from there. So that's why we're just going to really focus on decreasing the inflammation associated with the underlying disease. We're going to support them in any way we can, whether that means we need to do, ventilation or, pressors for their blood pressure or whatever the case is. We're going to really try to just support their vitals. So moving on to our next case, we have a 65-year-old male. Notices some easy bruising, some gum bleeding. He's recently started on warfarin for AFib. He has ecchymoses on his arms and legs on exam. His PT is elevated or prolonged, and he also has an elevated INR. He denies any significant dietary changes. So what's his most likely diagnosis and what's the treatment for his condition? So kind of a weird way to ask this question, but let's say, um, what do you think's going on in this case?
So yeah, it sounds like he recently started warfarin for AFib. So, you know, the question is, he has some ecchymoses. His PT is elevated, but that's expected in the setting of starting warfarin. So, treatment is just making sure he's in a therapeutic coagulation range. I mean, you could give vitamin K, but I don't think that easy bruising alone is an indication for maybe the gum bleeding, but for switching off warfarin, because I'm not sure why um, if he can maybe get an ablation for the AFib or something like that.
Yeah, very good. So, vitamin K deficiency, specifically in this case, this is drug induced. The pathophysiology of basically, you could view it as a warfarin overdose, putting air quotes around that. You can have a deficiency in those vitamin K associated factors, 2, 7, 9, and 10, as well as protein C and protein S. But obviously, we have mentioned this before with the warfarin induced skin necrosis, those protein C and protein S are going to be affected first. So because you have those deficiency in those factors, you're going to have the prolonged PT because of factor 7 playing into that being the most specific to measure. The presentation, you can see the petechial rash. You can have ecchymosis tends to be the more common presentation of this. Maybe some hematomas. You can have oozing at a surgical site if in a post-op patient, you've restarted warfarin. Now they're kind of bleeding a little bit. Their labs, we've already kind of mentioned this as well. So what would we kind of see both your PT, PTT, bleeding time, and platelets, Mike? What do you expect?
So I think the only one that would be abnormal, so both the PT and PTT would be prolonged because you would be affecting both the extrinsic and intrinsic pathway, but you'd have a normal bleeding time, and then your quantitative and qualitative platelet function is would be remain the same.
Very good. So because 2, 7, 9, and 10, 7 obviously being extrinsic and 9 and 10 being kind of in the common factor or the common pathway, you're going to see both the PT and PTT be prolonged. You're going to have normal bleeding time, normal platelets. Some high yield facts about vitamin K specifically. So newborns lack gut bacteria that produces vitamin K, so they need prophylactic vitamin K shots at birth to prevent bleeding. Specifically on a test, they like to go after intracranial hemorrhage or interventricular hemorrhage (IVH) as a complication, specifically of prematurity, because they have even higher risk of vitamin K deficiency. And then you can also get a vitamin K deficiency with malabsorption. So specifically these A, D, E, and K, the fat soluble vitamins. So this can be seen in conditions that are with like pancreatic insufficiency. So things like CF, Crohn's disease, I think can even get there. Other fat malabsorption syndromes as well. And then long-term antibiotic therapy, if you kill off all the bacteria that are producing this vitamin K, you can get kind of a similar picture there where you just don't have the vitamin K in the body, similar to these newborns with the sterile gut. So treatment kind of depends. Vitamin K, you can replace it and kind of replete it. You can hold the warfarin, obviously, maybe change medications if you can, like Mike was saying, maybe refer them for an ablation so they don't have to be on warfarin anymore. Dietary changes. This guy says he hasn't changed anything. Check out our part one of our hematology review has a really good section there on what to do with different settings of warfarin and elevated INRs. So that's good to know because it is a very common problem that we deal with. And it's kind of the fear of using warfarin is that it's so variable, whether because of diet and some people are slow or high metabolism, or metabolizers of this drug, and then all the interactions with other medications as well. So good to keep in mind with warfarin and associated vitamin K deficiency. So now we're going to talk about a 25-year-old female, and she has heavy and prolonged menstrual bleeding or menorrhagia. She's gone through several extra absorbent tampons, no success, so she's still bleeding. As a child, she's noticed several episodes of unexplained nosebleeds. Her labs show normal PT and normal platelet count, but does have a prolonged PTT. What are you expecting here in this patient as a diagnosis?
So at first glance, the prolonged PTT and easy bleeding makes me think of like a hemophilia or something like that. But also, it looks like she's had, with the menstrual bleeding in particular, if it's not oozing and then also the nosebleeds, it looks like it could more be the von Willebrand's factors deficiency, and I'm seeing that in the chat as well. So von Willebrand's disease is what I'm kind of leaning towards, which, as we mentioned earlier, von Willebrand's factor is a stabilizer of factor 8, so it can present with elevated PTT.
Awesome. Yeah, so be thinking of von Willebrand disease. The pathophysiology, this is either deficiency or dysfunction of von Willebrand factor. Um, you'll have reduced platelet adhesion and impaired primary hemostasis. If you want to review that, go back to our part one of our hematology review. And at the end of the day, since you have less von Willebrand factor, you're going to have increased degradation of factor 8. So secondary hemostasis is also going to be impaired to a certain degree. So, clinical presentation, I would say the most common thing I've seen is mucocutaneous bleeding. So, usually epistaxis or bleeding gums, things like that. It usually doesn't get too severe, but obviously menorrhagia can get pretty severe. You can have a pretty gnarly anemia from that. They're also going to maybe have a family history because this is an autosomal dominant disease. So the classic diagnostic test. So give me this, Mike. What would be the classic diagnostic test that might be kind of tested as more of a buzzword? And then what would you kind of see on labs as far as your platelets, your PTT? And we already kind of talked about that, so you don't have to go over it if you don't want to.
Yeah, we actually got this question when we were on a medical Jeopardy team together,
We
but
did.
it's yeah, ristocetin assay would be abnormal, but basically PT and platelets would be normal. PTT would be, slightly elevated, like we mentioned in the question stem.
Perfect. Yeah. So the abnormal ristocetin cofactor assay, ristocetin's an antibiotic. And then the normal platelet count. So this is specifically going to be a qualitative, not a quantitative platelet problem. And then the PTT may or may not be elevated. Reason I kind of made it elevated in the question is to highlight that interaction with factor 8. But how do we treat? We already kind of mentioned this before.
Desmopressin.
Very good. So desmopressin or DDAVP, synthetic ADH, will increase the release of von Willebrand factor, and therefore will also stabilize factor 8 as well. So you should hopefully be able to treat with desmopressin. Now, in some cases, if it is super mild, um, then you don't necessarily have to treat. A lot of times, this condition is completely asymptomatic, but if they are going through like someone like in this case where she's very she's very symptomatic, excuse me, and she's having like drastic lab abnormalities, like if she is truly anemic, then desmopressin is not a bad idea for this patient. So now, kind of get more into another pediatric case. So we have a 3-month-old presenting with bleeding along the gum line. They have some petechiae, some purpura along the extremities, but their CBC returns normal with platelet count. But the infant does have increased bleeding time. So what that tells me is that this is not a quantitative. There's nothing wrong with the number of platelets, but it's a qualitative problem. So something's wrong with the way the platelets work. So what's our diagnosis, do you think, Mike? This is kind of tough.
Yeah, this one is tough. So 3-month-old with bleeding and petechiae. So the petechiae and purpura make me a little bit concerned about a platelet problem. So there's a normal platelet count, but increased bleeding time. So there's no quantitative defect, but there's a qualitative defect in bleeding time. So, a lot of different things can cause qualitative defect in bleeding time. So in adults, you worry about renal failure with uremia can cause a qualitative platelet defect, but in an infant, you the difference is basically down to Bernard Soulier and Glanzman's. I see Bernard Soulier in the chat, so I'm not really sure how to differentiate between uh, Bernard Soulier and Glanzman in the chat, but would probably just get a blood smear and a CBC and look for those associated mutations.
Yeah, very good discussion there. So this one specifically is going to be Glanzman. This is more about what I'm not giving you rather than what I am giving you. The pathophysiology behind Glanzman is an autosomal recessive bleeding disorder caused by decreased GP2B3A, and that's going to inhibit platelet to platelet adhesion and platelet plug formation. So your presentation, much like this patient's going to have this mucocutaneous bleeding from birth, petechiae purpura. Diagnostic testing, like we mentioned, this is not a quantitative problem. This is a qualitative problem. So this patient does not have thrombocytopenia. Their platelet function is just decreased. Treatment is going to be with scheduled treatment and platelet transfusions. And like Mike said, the big differentiating factors if you were to do further genetic testing and a blood smear. So a blood smear would be more easy to do initially with genetic testing as a confirmatory type test. So now, very similar case. Now they're a little bit thrombocytopenic, but their aggregation studies show no response to ristocetin, and it doesn't correct with addition of normal platelets. Their PBS shows large platelets. So we have once again kind of both a quantitative and qualitative, but for the most part, you can still kind of see a qualitative defect since they don't respond to ristocetin and it doesn't correct. So with the large platelets, what's our diagnosis here? And Mike kind of already brought this up. So this is Bernard Soulier, specifically with the large platelets being the pathognomonic finding on the blood smear. The pathophysiology here is an autosomal recessive platelet disorder. You have a deficiency in the GP1B receptor, which binds von Willebrand factor. So you're going to have impaired platelet aggregation, and that's going to decrease the specifically, and like we mentioned in our first hematology review session, the platelet and exposed collagen or the platelet and vessel wall interaction that kind of happens right off the rip. So clinical presentation, once again, very similar with the mucocutaneous bleeding. The labs are very much similar to what we would see last time, except a lot of times we see this abnormal ristocetin assay being thrown in. In the way, I believe Pathoma came up with this first, so I'll give credit to the great Dr. Satar. Um, Big suckers as far as Bernard CA, meaning like the big platelets being kind of a high yield point to bring out. That is a differentiator that you can see even on peripheral blood smear. Treatment, we're really, for both of these cases, we're going to be supportive care. We're going to avoid antiplatelet medications. Um, Platelet transfusion if you need to do surgery or if you have like life-threatening bleeding. But for the most part, if these aren't causing too much for symptoms, they don't really have to be done. Like too much doesn't need to be done about them, but it's good to know about them and specifically know their pathophysiology. More for step one. Also, the PEDS shelf could be very high yield as well. So just a couple quick cases there. So kind of going in to this big overarching concept of venous thromboembolism or VTE. So, Mike, can you kind of just give me what comes to mind when I ask you, like, what's risk factors, general risk factors for VTE?
So I think of Virchow's triad, but otherwise, that's a little bit step one-y. So Virchow's triad is your endothelial damage, venous stasis, and hypercoagulability. But really, clinically, the main thing we think about is hypercoagulability are things you can work up, especially cancer, any hormones, especially like OCPs or pregnancy or genetic causes, like we mentioned before, and endothelial damage as well can be a risk factor, but and also just any stasis, like sitting on a plane for a long time or immobilization in the hospital or after surgery or something like that.
Very good. So knowing Virchow's triad and just the kinds of things we think about as far as what medications make you hypercoagulable, cancer definitely does, the genetic disorders that we talked about earlier, and then more lifestyle things like what's their, is there any risk factors for venous stasis, like you mentioned, long car ride, long flight. The clinical presentation of VTE, um, for DVTs, usually what you're given is a unilateral, warm, swollen, tender lower extremity. A positive Homan sign can be seen on exams, but it has very poor specificity and sensitivity in real life, and that's the pain on dorsiflexion of the foot. The real thing you want to be looking for is a difference in circumference between the two legs, the swelling being the main thing that's seen with the affected extremity. And then downstream of the DVT can be the presentation of pulmonary embolism. So this picture of chest pain, they have dyspnea, could have a fever, they're tachypnic, tachycardic, hypoxic, and even can lead to death if you have one big enough to cause kind of signs and symptoms of obstructive shock. So the diagnosis of a DVT. So what would you do? So we already kind of mentioned the physical exam findings that would kind of go into your thinking, but what diagnostic test or imaging would you go after right away?
Probably start with like a ultrasound. If it's a lower extremity DVT or even upper extremity DVT, but if you're worried about something like a PE, then would move on to a CT angio, spiral CT.
Very nice. Yeah. So first thing we're going to do, obviously you're going to go look at the patient and do a physical exam, but then reaching for the lower extremity Doppler is a good place to start, less invasive, less expensive. And then for a PE, especially if you have high suspicion, the CT angiogram is the gold standard imaging test there. Getting an elevated D dimer obviously supports your diagnosis, but as an initial step or something to do, unless in very specific scenarios there can technically be a reason for a D dimer, but in most cases that's not going to be your correct answer. So treatment depends on how our patient's doing. So let's say we do have a VTE that's turned from DVT to PE and this patient's unstable. What do you do, Mike?
If they're unstable, well, I would call the PE kind of response team, but the kind of next step is for unstable patient is consider if thrombolysis would be indicated. Definitely starting anticoagulation, probably a heparin drip if they'll need like some kind of anti or thrombolytic with IR or something like that. But probably would think about relieving the obstruction and then supportive cares as well. But usually, relieving the obstruction would be required in that.
Yeah, so what I want you guys to know is that if they're unstable, we need to take drastic measures. And a lot of times on exams, that's going to be a fibrinolytic. So giving TPA to these patients is an appropriate decision if they are truly unstable. So if they're showing signs and symptoms of shock, like really low blood pressure, super tachycardic, the patient just looking sick. So now we think if they are a little bit more stable, you don't necessarily have to reach for those. Now you can kind of treat with anticoagulants rather than antiplatelet agents. So these are going to be things depending on the depending on the situation you're in. They might give you a situation where Lovenox is better, or a heparin subcutaneously, or a heparin drip might be better. DOACs can be used even outpatient if it's a small enough DVT, like one that you can find in clinic. You can even go as far as treating that outpatient just with a DOAC. So that's kind of changed. Back in the day, you usually had to, admit somebody and do a heparin and bridge into warfarin or something like that. Prophylaxis is very high yield to know in the hospital. Typically, this is done with Lovenox unless they have kidney disease where they don't clear it as well. Then you can do either like subcutaneous heparin that's metabolized in the liver, um, or you can do, like I mentioned, yeah, therapeutic heparin, the Lovenox, DOACs if they're stable. So there's a lot of ways to treat these, and there is more detailed kind of thinking about this in our part one video, I believe, with the anticoagulants and kind of when we use them. So a very high yield topic. What's the most common EKG finding in a pulmonary embolism?
I've actually gotten asked this many times. I believe uh it's you can either be a normal EKG or a sinus tach.
Yeah, so if they ask what's the most common abnormality on an EKG, it'll be sinus tachycardia. Notably, there's a lot of talk about this S1Q3T3 pattern that can pop up specifically with PE, but really it's not as common as sinus tachycardia. It can be used. It's kind of more of a right heart strain pattern, I believe. But if they ask you what's the most common, it's usually just going to be kind of textbook sinus tachycardia. And what's your kind of building on that most common chest X-ray finding in pulmonary embolism?
This one I know is no finding, but you can
Yeah.
actually see like the wedge-shaped infarct.
What's that called?
Oh, I don't remember. There's a sign name for it though. I don't remember what
Yeah,
it's
it's
called.
I believe it's the Hampton hump is what it is.
Yeah, that's right.
But yeah, I've never actually seen that on a chest X-ray. In most cases, that's completely clear. So good to know those two things as they're kind of trick questions where they're trying to get you to say something when really not much is going to be seen on the EKG or the chest X-ray. So kind of going into just this general approach to anemia, I kind of just wanted to lay this out in general. We have some cases to go along with it as well, but in general, when we look at anemia, we're first thing we're going to do obviously is look at the CBC, and the first kind of branch point to create our differential diagnosis is going to be based on the MCV or the mean corpuscular volume. Are they microcytic? Are they normocytic? Or are they macrocytic? So get that out of the way right when you see the question and they're anemic, the hemoglobin's low, classify it into one of these three categories and kind of start working your way down a differential. So let's talk about this patient. 65-year-old man, 3-month history of fatigue, lightheadedness with exercise. He just feels more out of breath. On exam, his conjunctiva are pale and he has tachypnea. So what's kind of our next steps? We already kind of talked about the first test that we would get. So where would we go first, Mike?
So the next steps that I would think about are getting probably CBC. I would probably get some other labs like TSH, magnesium too, but the big one here with the conjunctival pallor, that actually is a pretty good sensitivity and specificity for anemia. So we definitely want to get CBC and probably iron studies.
Very good. So we obtained that CVC. His hemoglobin's 9 with baseline in the past of 15. His MCV is a microcytic, slightly microcytic. Now you obtain your iron studies. You see low serum iron, ferritin's low, TIBC is actually high, transferrin percentage saturation is also low. So what's our diagnosis now with those that set of lab findings?
So looks like iron deficiency anemia, especially with microcytic anemia.
Very good. Yeah. So low iron, low ferritin. Diagnosis we're looking for is iron deficiency anemia. So how do we treat iron deficiency anemia in general? So let's say we suspect this is more of a nutritional cause or we have a nice reason for the iron deficiency. What are we going to do?
Would probably start off with iron supplementation, but then would want to evaluate for any causes of like blood loss.
Very good. So treatment is going to be iron supplementation. And then what else do we do? Like Mike said, now we're going to try to work up um, secondary causes of iron deficiency, which usually uh, the thing that you need to have high on your differential is some source of bleeding. Most commonly on exams, they want you to have a very high suspicion for colonoscopy. Like I have said here, new iron deficiency anemia in a 65-year-old is colorectal cancer until proven otherwise. So definitely go after that colonoscopy and rule that out before we go and do other things. Other screening, if indicated, like if they're an alcoholic, and you suspect maybe there's some play of variceal bleed in the picture, doing a screening EGD to see if those could be bleeding, or some risk factors for gastritis. Maybe they have melena and you think something upper GI. But a lot of times, what they want to do first is a colonoscopy. So we have a couple mnemonics as well, I believe. Yes. So our tails mnemonic for microcytic anemia being thalassemia, which is just that globin chain deficiency, the anemia of chronic disease, iron deficiency, lead poisoning, sideroblastic anemia. So these are the things that we kind of see pop up when we're talking about microcytic anemia. So thalassemia, they could ask you this in a younger patient, obviously, because this is a genetic defect. Anemia of chronic disease, in my experience, you're often seeing this in the context of like long-standing rheumatologic disease, maybe even malignancy. Straight up iron deficiency from like a slow bleed or malabsorption or just like chronic bleeding. Um, so good to know that one. And then lead poisoning and sideroblastic anemia, which kind of have these very kind of anomalous causes that are kind of hard to place. But knowing sideroblastic anemia being associated with B6 deficiency is high yield. And then remember that lead poisoning, lead inhibits that ALA dehydrogenase enzyme that I believe is in the early parts of the heme synthesis pathway. So that's kind of how you get there. So another kind of just high yield thing you need to be able to do is know how to interpret these iron labs here. So the serum iron, the TIBC, the ferritin, the percentage saturation, and then using the CBC with the RDW and MCW. Um, Specifically, as you can see in this chart here, very high yield. Knowing the iron deficiency in general, we're going to have decreased iron in the serum. We're going to have decreased ferritin, which is kind of our measure of iron stores. And we're going to have increased TIBC, or total iron binding capacity, which means there's a lot of free space for iron to bind and it's not being filled. So knowing that is very high yield. And then the inflammatory anemia or anemia of chronic disease is the big contrast. So here we have decreased serum iron, but increased serum ferritin and decreased TIBC. So in that case, if you remember the pathophysiology behind anemia of chronic disease, we'll go into it in a little bit. Um, but it's very good to know that difference in the ferritin specifically. So we'll get into that. So we have this 55-year-old female. Her past medical history is significant for rheumatoid arthritis. She's on methotrexate for that. She also has Hashimoto's disease, hyperlipidemia, presents for a routine well visit. She's up to date on all of her cancer screening, but her routine labs show hemoglobin of 10 with a baseline of 12 to 13. So she has new anemia. So what's our next best step? We already kind of talked about this. What do we do?
So this would be another reason to grab a um, iron studies as well. Still likely iron deficiency anemia, but might not necessarily need to work it up much further if it were a young female. A 55-year-old, you would still consider further workup for iron deficiency.
Absolutely. So next best step, we're still going to do those iron studies, but you see that the studies don't correlate with iron deficiency. So now what are we thinking in this patient? What's kind of your most likely thought?
So I was watching a camel eat a cactus on my phone, but so if it's not iron deficiency anemia, then uh, you might be thinking of like anemia of chronic disease if this patient has had rheumatoid arthritis. So you could think about seeing that elevated ferritin.
Perfect. Yeah. So then what are our expected labs? Like I said, very high yield to know. Iron, serum iron is low, ferritin is high, TIBC is low, and iron saturation is low. So the way I think about this is that because of the effect of chronic inflammation, the iron is going to be stuck in the precursor cells and not able to be transferred to be used. So it's going to be stuck in kind of our storage form of ferritin, but our serum iron is going to be low. But since it's still present, we still have iron and it's still bound, we're going to have TIBC be low as well, rather than in iron deficiency where it's high. We're also going to have that low iron saturation. Treatment is going to be based on treating the underlying condition. So whether this patient's RA is uncontrolled or their Hashimoto's is out of whack, whatever the case is, we're going to look for the underlying condition. And the pathophysiology, like I mentioned, increased inflammation is going to increase the effect of cytokines. Specifically, what's good to know is this mediator called hepcidin, and that's going to cause decreased iron transfer from macrophages as well as less EPO being produced. So you're going to have this kind of combined pathophysiologic mechanism leading to our anemia of chronic disease. So very good to know, and especially these lab values here. That's kind of the big takeaway. And just knowing what kind of patient they're talking about it in. Since she's up to date on her cancer screening, has a history of chronic inflammation with autoimmune disease, that should steer your mind in the direction of anemia of chronic disease. So now we have a 60-year-old male, and his past medical history is significant for alcohol use disorder, and he's being worked up after being found down in the cold. Notably, he was also receiving treatment for tuberculosis starting last month. Basic labs show anemia, iron studies are ordered, ferritin, serum iron, and transferrin are all elevated, but his TIBC is normal. So what are you thinking in this patient with all these risk factors and then those associated lab findings, Mike?
Yeah, it's probably a microcytic anemia. Yeah, medication side effect in the chat. So it's probably from in ripe therapy, pyrazinamide. What is it? Yeah, so rifampin, it's isoniazid, pyrazinamide, and ethambutol. So isoniazid can cause B6 deficiency. So it's probably sideroblastic anemia from B6 deficiency. Also,
Very
side
good.
note, Tate, did you know that camels ate cacti? I didn't
I think I
know
had seen
that.
that somewhere, but I've never like seen it with my eyes.
Yeah, I've been watching those videos. Pretty
Do they have
interesting.
like specific biology that makes them like, do they not care about the spikes?
I don't know. I'll look into
That's
it.
their primary source of water. Xander, how do you know that?
Real, is that true, Xander?
There's no way. What?
That's actually pretty.
That's kind of crazy. I mean, I know that the cacti like they store the water. How else do they get it in the desert? I don't know. They find an oasis or something, or humans give it to them. I don't know, man. How many wild camels are there?
They go to the resident lounge.
They go to Oh, that's crazy. So, guys, if you have any questions about like nature or like animal biology, Xander's your man. He knows. So we have our email listed on the front of our like our front of our slides, our title slides, as well as in the description. It should be there as well. So definitely hit us up with all of your animal biology questions and we'll get those right to Xander. So back into our talk here, sideroblastic anemia. The pathophysiology specifically in this case is going to be decreased heme synthesis, and the iron is going to be trapped in the mitochondria. Like Mike had mentioned, in this case, they have B6 deficiency, and B6 is a big cofactor in the heme synthesis pathway, so that's going to lead to that decrease in synthesis. The iron are going to be trapped in the mitochondria and are not available for the rest of the cells to use. Our treatment is going to be B6 supplementation. So everybody on isoniazid should be supplemented B6 because as like I just mentioned, the cofactor for those synthesis enzymes in the heme synthesis pathway. And then we're going to cease the offending agent. Obviously, this patient's kind of in a bind because isoniazid is an important component of the tuberculosis treatment. But if we do have some other medication that could be causing B6 deficiency, then we would want to cease that. And like we just mentioned with sideroblastic, B6 deficiency, specifically tied to INH, lead poisoning can get you to sideroblastic anemia, alcohol use, MDS, malignancy, and even copper deficiency. I would say, in my experience, the B6 deficiency is probably the most high yield, even tied to isoniazid, also very high yield. And then lead poisoning and alcohol are kind of go back and forth for that second most common spot. So as you can see with our sideroblastic anemia, we have our basophilic stippling, as you can see there, which can be associated with like lead poisoning, alcohol use, all those other causes. And then there in the bone marrow would be our ringed sideroblast that we would see. So those findings kind of would be a good opportunity for them to see and test your ability to read both a blood smear or a bone marrow. As you can also kind of see in that blood smear on the left, you can see that the central pallor is enlarged, kind of indicating this hypochromic and also kind of microcytic picture. So just kind of keeping in mind that those are also just normal characteristics of the blood cells that are worth mentioning. Obviously, the basophilic stippling hops right off of the page, but good to also keep in mind those peripheral features. So as you can see, there's kind of my, you'd use Prussian blue to kind of see that ringed sideroblast. As the iron is stuck all in the cytoplasm in the mitochondria, like we mentioned, it would stain all that blue and you'd get that nice ring formation. So now we move on to our normocytic anemia and kind of what we're thinking when we go through that. So really for the purposes of diagnostic reasoning, when we see this normocytic anemia, the first place my mind goes is to consider whether this is hemolytic or not. So how you can differentiate that is largely based on the reticulocyte count. Um, because as you can see there with a low reticulocyte count, we are less suspicious for hemolysis. As you know, when our blood counts are dropping due to hemolysis, especially something acute, we'll have an increased reticulocyte count in response to that anemia. So if it is normocytic and our body is not feeling the need to replace it, and we're going to be kind of putting ourselves in a more non-hemolytic family of diseases. So kind of things to keep in mind when we're talking about these is going to be things like early anemia of chronic disease or iron deficiency. Actually is very high yield. They'll tell you, this patient has an acute GI bleed, or they had a diverticular bleed where they lost a lot of bright red blood per rectum. What would you expect their iron studies to look like, or their CBC to look like? And in that case, with an acute pathology, the MCV will not have time to show the characteristic microcytic anemia of iron deficiency. So you're going to have a normocytic anemia in those patients in that acute phase. Also, things that can cause it would be aplastic anemia. So reasons why we would have like bone marrow suppression, and then CKD as well, just due to decreased synthesis or decreased EPO, are all things that are just going to cause not any problem with the size or the amount of iron in the red blood cells, but just the rate of synthesis is going to be suppressed in all those cases. So now we kind of move on to what are our hemolytic causes of normocytic anemia. So these are going to be things either related to the red blood cell or our intrinsic things versus our extrinsic or extravascular causes, where something is being imposed on the red blood cells. So whether that be autoimmune causes, microangiopathic causes like we talked about earlier, or like hypersplenism where the macrophages are taking in those red blood cells within the spleen and causing more of an extravascular hemolysis picture. So obviously not going to go through every single cause of intrinsic hemolysis here. or intravascular hemolysis. As you can see, a lot of them do end up coming down to genetic things. So you have your hereditary spherocytosis, and knowing the elevated MCHC is very high yield, and the treatment with splenectomy also. Your paroxysmal nocturnal hematuria, with their defective CD55 and 59 anchors, makes you very susceptible to complement mediated hemolysis. So that will be DAT negative, which is kind of a unique feature. So you don't have any antibodies causing that. It's because it's complement mediated. And the treatment of that is actually done with eculizumab, which is an anti-C5 monoclonal antibody. And Mike, this is kind of actually, I've seen this quite a bit. If you give somebody eculizumab, what infection are they at higher risk for?
Is it Neisseria? Is it the terminal complement path?
Very good. So since you're inhibiting C5, you're also inhibiting that C5 to C9 membrane attack complex or the MAC, which is important in fending off Neisseria infection. So you're basically giving them an acquired terminal complement deficiency with that drug. So high yield to know that as well. So you'd want to definitely vaccinate against the Neisseria species that you can. G6PD deficiency. That's your classic fava beans, sulfonamides causing toxicity or hemolysis because of that deficiency in that member in that enzyme. You'll see your Heinz bodies and maybe even bite cells on your peripheral blood smear. And then obviously sickle cell disease, they usually present in pain crisis. You can treat that with hydroxyurea in vaccination against encapsulated bugs, as well as also very, very high yield daily penicillin until age 5. So that's good to know. And Mike, can you tell me why do we give the hydroxyurea? What does that actually do for these patients?
I think hydroxyurea that basically had like a serendipitous finding that it increased the level of HbF, like the fetal form of hemoglobin, which essentially works to is better at carrying oxygen than the HbS, which is the sickle cell hemoglobin.
Yeah, very
It's
good. Serendipitous, kind of definitely a choice of words, but yeah, so hydroxyurea is going to increase the production of fetal hemoglobin or HbF, and we don't know why or how, but it does. And HbF, when in the blood cells, is less vulnerable to sickling. So that makes them, in general, less likely to have these pain crises. But also, we're going to, advise them to stay hydrated and to keep in mind, like, when they're infected, to have a high index of suspicion for like being at high risk for these sickling crises. So daily penicillin, I question in the chat, like what's the penicillin for in sickle cell? Penicillin just covering like the strep pneumos of the world and those more basic bacteria with encapsulation is kind of what I've always thought about with it. Specifically penicillin, I think you can probably give amoxicillin as well. I know that just the typical answer in those questions is going to be the daily penicillin until age 5 is very high yield. So yeah, definitely want to defend against strep pneumo, as strep pneumosepsis in a sickle cell patient or an asplenic patient can get out of hand very, very quickly. So that's what we're giving that for.
Yeah, I think it's especially the risk of asplenium in sickle cell patients.
Yeah.
You know, Tate, I was actually watching some cooking TV show the other day, and they
Mm-hmm.
actually had fava beans. I didn't realize I thought they looked like peas for some reason, but they actually look like kidney beans.
Oh, yeah,
They're
like
like
I
a
always thought
bigger
like they look
bean.
like lima beans, kind of. Yeah, yeah.
Yeah, that's what they look like.
What were they making, bro?
They made like it was like they were using like rabbit liver and fava beans over
Ew.
like Parmigiano Reggiano. It was like one of those. It's like Iron Chef or something on the
Mm,
cooking channel. It looked good.
wild, bro. Do you cook, Mike? What do you cook?
Yeah, I cook. Let me cook. I'll send you a picture. I had a potluck the other week. It was good.
Well, what do you like? What's like your go-to breakfast right now?
Breakfast. Oh
Mm-hmm.
man, probably
Because well,
black
you didn't really eat
coffee.
when I was on rotation with you. I don't think I ever saw you eat anything except like eggs and vegetables.
Yeah, well, that's because that's the breakfast where we were at. It was good, but no, there's that one day on cards when I was like binge eating. Remember that?
I do remember that.
Yeah. What do I eat for breakfast? I usually just eat honestly eat leftovers for breakfast, but like oatmeal
Gotcha.
and I eat chicken and rice a lot. It's
Do
an
you have
honest
like a
meal.
signature meal though? Like, do you have something that you think you're really good at making?
Signature,
Yeah.
probably fried noodles, 炒面, or My kanji's pretty good. Um, Probably teriyaki chicken though, like chicken thighs,
Very nice.
like stir fry.
I could see you in the kitchen cooking stir fry, bro. Shout out to, wasn't that Migos who made that song? It's a banger.
Yeah. What else was I gonna say? Oh, with the what drug? Do you know what medication you always have to check G6PD for?
Oh, snap. Um, it's before you give malaria treatment in it.
I think treatment can cause it, but there's one in dermatology in particular. Let's say they have celiacs and they have a cutaneous manifestation. What medication do we start?
I think Xander just got it.
Yeah, it's Dapsone.
Yeah, I remember that now in the old sketchy. Yeah, Dapsone, that's good. I thought, yeah, you need to test for it before you do I think it's Primaquine, like when you're trying to do like Vivax and Ovale treatment.
I think so. I mean, yeah,
I think that one
we
too.
prescribe a lot more Dapsone than
Yeah,
that, but
that's fair. I guess Dapsone is
but
probably a lot more common than malaria treatment here in the US. So, all right, well, let's keep kind of carrying on here. I say we can get it done in another half hour. We got to be at least close. Got to be somewhat close.
I'm in.
So,
Let's rip. Let's cook.
let's cook. All right, let's do it. So macrocytic anemia, let's kind of just talk about it. We have MCV greater than 100, obviously. We're going to consider whether it's megaloblastic or non-megaloblastic in nature. So you differentiate that specifically on blood smear by seeing the hypersegmented neutrophils. So megaloblastic meaning that there's something going on with the division of cells rather than just the volume of the cells being high. You also have this kind of component that the division of the cells is kind of altered. So the causes of a macrocytic and megaloblastic anemia, these are going to be things B9 and B12 deficiency most of the time is what you're going for here. So both of these vitamins are going to be important in DNA synthesis. So if you have problems or deficiencies of those, you'll also have problems with your ability to kind of cell divide and replicate the DNA as well. So that's why you get these hypersegmented neutrophils. How do you differentiate between B12 and B9? So what level would be high in B12 that would not be high in B9?
MMA.
Very good. So MMA or methylmalonic acid is only going to be high in your B12 deficiency. Let's kind of talk about some of the ways they like to test this because really these folate versus B12 deficiency, they're both very high yield causes, and most macrocytic anemias are going to be megaloblastic in nature. So let's say this person has a history of other autoimmune diseases. So in this case, maybe I would personally lean towards a diagnosis of B12 deficiency, specifically due to pernicious anemia, which is that autoimmune attack um, against the intrinsic factor. So you're going to have this intrinsic factor deficiency, which means you can't bind to B12 and will have less absorption of it. Now let's say they're an alcoholic or they have a history of malnutrition along with that. This one can be really difficult because really, for the most part, I lean folate deficiency in these patients. It can be difficult because they are also at risk for B12 deficiency. But one of the big things with B12 is that the storage of B12 sticks around for a long time. So you have to have a really chronic process to get B12 deficiency, where less so with folate. So unless this is a really very, very, very chronic process, then I would usually lean folate. And then let's say you have a patient that's on methotrexate. Um, in this case, I would be thinking folate deficiency, but what do we do with patients on methotrexate that might need prevention of folate deficiency? What do we do? What do we give them?
They get folinic acid.
Good. Folinic acid or leucovorin. It's also kind of something to note, like in cases of like pediatric cancer where we treat it with methotrexate, you can give like very, very high doses of methotrexate and then do what's called a leucovorin rescue, where you kind of get them really, really low and then kind of supplement them at the last second to kind of bring them back. So as you can see there's our hypersegmented neutrophils. I believe if there's greater than, I think it's five, kind of lobes of the nucleus in there, or like the basophilic kind of inclusions there. If you can have greater than five, I believe that is that. Don't quote me on that. I feel like I've heard that somewhere. But being able to recognize this picture in particular is very high yield for exams. And then here I just kind of have a little secondary picture of both B12 and folate being needed for DNA synthesis, and kind of how the MMA gets elevated in the setting of B12 deficiency. So let's kind of go into some cases. We have a 42-year-old female. She's in the clinic complaining of diffuse arthralgia. She also has some fatigue. She reports no recent infections. Her physical exam is largely benign, with the exception of a few mucosal ulcers. Initial labs are actually significant for a pancytopenia type picture. You have the hemoglobin, white blood cell count, and the platelet count there, and a mildly elevated creatinine. What are you thinking for this woman here?
It sounds like we've got enough clinical criteria for lupus for SLE, especially with the lab findings.
I would definitely be suspicious of SLE. Pancytopenia, arthralgias, fatigue. You have that right demographic of this middle-aged female that are very at risk for autoimmune disease, especially on exams. You have mucosal ulcers, a little bit of elevated creatinine as well. What's your best initial test? If they ask you what's the best initial test for SLE?
Got to be an ANA, right? See that in the
Perfect.
chat
Yeah.
too.
So ANA being the most sensitive, so it's good at ruling things out. So if you've ever heard like spin and snout, spin meaning a more specific test is good for ruling things in, spin, and then more sensitive things are good at ruling things out. So snout. So ANA would be the most sensitive. So if that ANA came back negative, you can be pretty darn sure that they do not have lupus. But what if they ask you what's the most specific test?
Is this the anti-Smith antibody?
Perfect. Yeah. So this is the anti-dsDNA, anti-double-stranded DNA, or the anti-Smith are both considered the more specific tests. Kind of a high yield offshoot point here. What's the most common cause of death in lupus patients?
I think it's infection.
Yeah, so I think technically it is infection. Um, and then closely behind that is going to be cardiovascular disease. I've seen both of these tested. I think it kind of depends on who's asking the question. I'm not sure what the exact stats are, but as you can kind of imagine, they have chronic inflammation, which makes them at risk for cardiovascular disease. You also have this risk of pancytopenia, which makes you at increased risk for infection. So both are very common things that could lead to death in a lupus patient. Um, so let's say this patient's having a flare of their lupus. So this is these symptoms that she's having, let's say, are different from or more severe than her normal, and she has these lab values which are away from her baseline. So what's your treatment both acutely and for maintenance?
So in the acute setting, usually a steroid burst or taper, and then also Plaquenil will be your DMARD or your disease modifying agent. So that would usually be, yeah, Plaquenil.
Very good. So, and what would we, if we're given Plaquenil or hydroxychloroquine, what side effect are we doing? What kind of exam should we be doing on a regular basis?
They need a ophthalmologic or eye examination. I think they get routine OCTs, which is like the ocular kind of like ultrasound because it can cause like retinal toxicity.
Yeah, perfect. So just know that you have to look at their eyes. Steroids for flares acutely, hydroxychloroquine for maintenance. Everyone should be on that for maintenance. It actually does pretty good. What if this patient has a history of recurrent pregnancy loss? We already mentioned this earlier. That should clue you into an antiphospholipid syndrome with that paradoxically elevated PTT value. And what do we do for treatment of antiphospholipid syndrome, both in and out of pregnancy? So we already mentioned the treatment in pregnancy is Lovenox, but what do we do if they're not desiring pregnancy or they're out of their childbearing window?
That would be aspirin.
Very good. Yeah. So in that case, you're just going to do aspirin. You would give aspirin plus low molecular weight heparin in pregnancy. The important thing to know is that that's what you would want to add if they are desiring or getting pregnant or are pregnant already. You'd add Lovenox to that picture. So we're going to kind of move into this quick hitting slide of infectious disease cases to keep in mind. So this patient has hemolysis, but they also have a cyclical fever. What does that make you think of? Two different infections.
One's got to be malaria.
Mm-hmm.
Oh, is the other one like I call it like Great Value malaria? It's a Babesia.
Good. Yeah. So malaria and then the American malaria is what I've always thought about it as is babesiosis. What do you see on blood smear of babesiosis, Mike?
Is that the Maltese cross?
Very good. And it's also good to know babesiosis. Obviously, this is not an infectious disease review. We'll get there someday on the channel, but babesiosis being treated with a macrolide like azithromycin as well as atovaquone, which is kind of just a unique cocktail of drugs for that. Um, let's say now you had a person travel to the Caribbean. Um, they have diffuse myalgias and bone pain, and they have thrombocytopenia. So, what does that remind you of?
The Caribbean, probably if they're thrombocytopenic, probably more like dengue. And then
Perfect.
if they're not thrombocytopenic or mostly anemic, it's like hemolytic anemia is more specific to dengue than chicken.
Yeah, very good. So dengue hemorrhagic fever is kind of what you think about there with that break bone fever. But like you mentioned, yeah, if they don't have as much anemia or thrombocytopenia, you can also go for chikungunya. I don't think they would test you against dengue versus chikungunya, but if they did, and they are thrombocytopenic and anemic, I would definitely be looking at dengue more closely. Both mosquito-borne infections there. Now let's say you have a kid with sickle cell disease, gets profoundly anemic, and has no reticulocyte count to speak of. What do you think of?
Probably like an aplastic crisis, maybe from like parvo B19.
Perfect. Yeah. So classically tested parvo B19, aplastic crisis. And then now, how about a high school kid with a dry cough? It has an atypical pneumonia, maybe reticulonodular infiltrates on a chest X-ray, and he has labs suggesting a hemolytic anemia. What do you think of?
Is he walking?
No, he's pretty tired. He's actually laying down.
Okay. Well, I was gonna say it's a walking pneumonia, mycoplasma, which can cause an IgM. So mycoplasma starts with an
Very
M,
good.
causes IgM mediated cold agglutinin and hemolytic anemia.
Very good. I like it. I like it. I like it. Now, kind of going right into the same kind of format. What about some farm heme cases to keep in mind? Let's say we have this 35-year-old female. She's at 12 weeks in pregnancy, and she's found to have Graves' disease or hyperthyroidism. And now she's leukopenic. What's the cause?
This is probably the anti-thyroid medication. I think they both can cause it, but it's more associated with methimazole.
Yeah, they can both cause it. So either PTU or methimazole. PTU is more tested in the first trimester of pregnancy. That's when you should give that, and then methimazole later on. Now let's do a 30-year-old male history of treatment refractory schizophrenia, and he's found to have pneumonia, and his CBC shows a pretty profound leukopenia. What's the cause of his leukopenia?
Clozapine.
Very good. So clozapine. And what are the other kind of side effects of clozapine that you can think of?
Oh man, it has a lower risk of drug-induced like Parkinsonism,
True.
but it can also cause like weight gain, your anticholinergic side effects. Um, those are kind of the main ones.
Yeah, I'm pretty sure you can also get a cardiotoxicity and I think seizures from clozapine as well. So it's kind
Oh
of,
yeah, lowers the seizure threshold.
yeah, yeah, good to know. Um, how about this one? We have a 25-year-old male, history of IBD, and now he's found to be leukopenic as well. What's your cause?
I think it's probably one of the meds, sulfasalazine.
Perfect. Yeah, sulfasalazine. Actually, a lot more high yield than I think it would thought it would be, and especially like later on in my studying, I found this out, and then I just kept seeing it. So, good to keep in mind. And now, kind of lastly, a 40-year-old female history of refractory epilepsy is found to be both hyponatremic and leukopenic. What kind of drug might be the culprit there?
I feel like this also gets tested a lot. This is carbamazepine.
Perfect. Yeah. So all of these, they might also be referred to as agranulocytosis. On labs, a lot of times leukopenia will be actually the way that it's kind of shown there. But agranulocytosis is also kind of the way to word that. So very good. We're going to kind of have some more kind of cases here that are very kind of, I would say, a little bit heme specific, but also like kind of just weird scenarios that kind of have a lot to them, but they're also just very characteristically tested. So we wanted to include them. So we have the 65-year-old male, his history of CAD, status post PCI times 2, PAD, hyperlipidemia, type 2 diabetes, presents to an outside hospital with crushing chest pain. EKG is similar to prior exams, troponin's mildly elevated. Prior to transfer to a tertiary center, he started on heparin, a beta blocker, and a nitro drip that results in improvement of his chest pain. Upon transfer, his current regimen is continued. His calf gets delayed multiple times due to emergent STEMIs. He's then noted by his nurses to be cyanotic and hypoxic to 85%, despite 4 liters of nasal cannula oxygen. But he only complains of a headache. What's your likely diagnosis? Long history here, but what's it getting at?
Did he get hydralazine or just
No,
nitro?
just
Either way,
nitro.
probably methemoglobinemia.
Perfect. Yeah. So, best next step to work up methemoglobinemia, what's that going to be?
ABG.
Good. So either an ABG, and sometimes they also say like co-oximetry to get a peek at it. Um, how do we treat this patient specifically? What do we do?
So methylene blue can actually reduce the Fe3 plus to back to Fe2 plus.
Perfect. And then what if they're like pretty much asymptomatic? This patient is symptomatic, so that's what we would do. But what would we also want to do along with
Just
giving
stop in the
methylene blue?
nitro drip.
Perfect. Yeah. So this is mediated by the nitro drip. So classic exam finding, there's already one in the question there. You would see um, kind of hypoxia that's like locked at 85% and can't be really changed from that. But what would you expect on classic exam finding? Maybe even like when you're drawing their blood.
Oh, like the chocolate colored blood. I'm
Yeah,
actually
I've
eating
never
some
seen this.
fudge Xander gave me yesterday right now. It's pretty good.
Fudge is pretty calorie dense, big dog. Cut must not be
I'm
on. I guess
bulking.
it's. Hey, we're bulking.
Winter's coming. No, not really.
Winter's coming.
I was just nibbling at it.
No, I got to do like a winter cut, bro. I'm the opposite way, bro. I'm losing it. All right. So yeah, chocolate colored blood. I've never actually seen this in real life or really tested on exams, but it's kind of maybe even a pimping question. So good to know. We have this 40-year-old female now. She presents to the ED with intractable headache. Her past medical history is significant for migraine, but this episode feels a lot different. She has a recent history of being at a birthday party with an indoor grill. What's your next best step?
It's just ABG City over here.
Yeah, it is. We're going to go after another ABG because what are you suspecting in this patient?
Um, so it's probably like an indoor grill. It seems like more specific than carbon monoxide. So maybe like cyanide. No.
Yeah, you're
Yeah,
absolutely
probably
right.
carbon monoxide.
Yep, I'm going after carbon monoxide for this. You might also obviously you have like the car exhaust in the garage, old heating units. So like in the middle of winter and they're using their heater a ton, whatever the case is, definitely getting you towards carbon monoxide. Let's say the scenario is a little bit different. She had a house fire and had inhalation injury on exam. So you see like soot in the back of the throat. What's your next best step?
So you'd want to evaluate the airway. Usually you can start with the airway evaluation and then intubation, but if you're concerned at all with the airway, it's always kind of safe to jump to intubation too. But
Perfect. Yep. You can also consider giving cyanocobalamin. There is like some association, like Mike had kind of mentioned a little bit. There is an association with cyanide toxicity, especially in these house fires and stuff like that. I believe there's something with like burning upholstery that can associate with cyanide toxicity. I think that's something with that. Um, how do we treat carbon monoxide poisoning if mild?
just like 100%, it's just oxygen. It's usually just supportive treatment for carbon monoxide.
Good. So you already mentioned it, 100% oxygen, but what else can you do?
Is
Actually, kind
this
of high
where you
yield.
give like hyperbaric oxygen? You're basically
Very good.
competing with the carbon monoxide for the available hemoglobin spots.
Exactly. So you're just trying to push that hemoglobin binding curve in any way you can, competing with that carbon monoxide. So whether that's 100% O2 or hyperbaric O2, can both be used. So here's something that I haven't seen tested yet, but I think it's getting there. So let's say, they have severe headache. You should get an MRI. What can you see on MRI specifically with carbon monoxide
I've
poisoning?
for
What
sure
area of
seen
the
this
brain?
tested. They'll like give you an MRI and
And you'll see it.
you'll see like globus pallidus.
Yeah, that's what it
Like
is.
yeah,
I have not seen that tested that I can remember, but yeah, it's becoming more common for sure. I've heard more and more about it. So this involvement of the globus pallidus, and then what would you expect the ABG to look like? So with the PaO2, the PaCO2, and then the pH.
so pH is I think normal actually.
I agree. Yeah, PaO2 is going to be normal, which is kind of high yield. Um, The PaO2 is this would be technically falsely normal. They're also probably going to be acidotic, but it's kind of a mixed picture. But knowing the normal PaO2 is very high yield for monoxide poisoning. So, kind of this next patient, we have a 52-year-old male. He's in the clinic with a complaint of blurry vision. He's noticed a darkened skin tone on his face, but it's summer, so whatever. He also describes episodes of intense itching that are worse when he uses the hot tub at his gym. His vitals are all within normal limits. What's your next best step?
Is this that like what they'll describe in question some as a ruddy skin tone?
I would say
So
that would be a reasonable way to describe
it's
this person's skin.
concerning for what's it called? Oh, basically, yeah, polycythemia,
Perfect.
um, due to too many red blood.
Perfect. Yep. So we're going to check a CBC for that hemoglobin and hematocrit. We'd expect them to be elevated in the case of polycythemia vera. Now, notably, if we have elevation in hemoglobin and hematocrit, and we don't have a patient with chronic hypoxia, that's when we're going to get suspicious for this. So, how would we confirm a diagnosis of polycythemia vera? What test would we do?
I think JAK2 genetic mutation is positive in like 95, 90 to 95.
Yeah,
Per-
it's a high amount. So you're going to do genetic testing for that JAK2 mutation. What would you expect the erythropoietin level to be in this patient?
and we're saying they have primary polycythemia vera,
That's correct.
then it would be low.
Perfect. And what if it was secondary?
Then it would be high.
Good. So the hypoxia is a stimulator for erythropoietin release. So if you had someone, let's say, with really bad COPD, you can have chronic hypoxia cause a secondary hypo or hyper or polycythemia, excuse me. So you're going to have a high hemoglobin, high hematocrit. Whereas in this patient, where the red blood, this is an intrinsic problem within the bone marrow where the JAK2 is causing increased production of red blood cells, that's going to negatively feed back on the erythropoietin amount produced. So it would be low in a primary polycythemia and then high in secondary disease. How do we treat polycythemia vera?
Basically bloodletting, so phlebotomy. And
Good.
then
And then what
aspirin
about
too, I think.
medications? You said it, say it again.
Aspirin,
And then what if you have to add another medication? Maybe if you wanted to decrease the production of red blood cells.
hydroxyurea.
Perfect. Very nice. Yeah. So phlebotomy and aspirin are mainly your kind of two mainstays. Phlebotomy to decrease that hemoglobin hematocrit, and then the aspirin to prevent the most likely complication, which is what, Mike?
That would be like thrombosis.
Perfect. Yeah. And a lot of times they test weird stuff, and I have that mentioned here. So maybe a portal vein thrombosis, maybe they'll have like stroke symptoms from it. So all that stuff might be the way that they go after it. And then yeah, plus or minus with the hydroxyurea, a ribonucleotide reductase inhibitor, which would decrease the production of red blood cells. But many times on exams, phlebotomy will be the right answer. Maybe they ask about aspirin as well. So, kind of moving into another case, we have a 25-year-old male. He's in the clinic after an odd episode of pain in his neck associated with drinking alcohol. He reports a 2-month history of night sweats and a swelling in his neck. On exam, there's a shoddy cervical lymphadenopathy with one dominant node measuring around 5 centimeters in size. What's your next best step?
Probably in this case, a lymph node biopsy, just because the node is 5 centimeter, and he also has some B symptoms with the night
Perfect.
sweats.
Perfect, perfect, perfect. So let's say, what kind of findings would you expect in this patient? Let's say, in this patient, the pain with drinking alcohol, the age getting together kind of raises my suspicion, at least for Hodgkin's disease or Hodgkin's lymphoma. So what would you expect on the biopsy of lymph nodes?
Would this be the Reed-Sternberg cells?
Good. So you'd have that bilobular nucleus, that owl's eye appearance. So let's say you do the lymph node biopsy and you think you get the results back, this is Hodgkin's disease. Then what are you going to do? This is actually kind of a high yield point for anything. So you get the biopsy and you know that you're dealing with a malignancy.
Are
Now
you
what?
referring to like staging? So probably start with a CT usually, for
Yeah. So
staging.
what?
So probably head and neck and
Yep,
chest.
CT, PET CT. It's actually, yeah, it is very high yield because that's kind of how it determines your management from an oncologic perspective, depending on the stage of the disease, and you determine that based on the spread. So, looking at the CT, looking at maybe even a PET CT for that. So, let's say now we decide to treat with ABVD. So, this is this regimen of like doxorubicin, bleomycin, vinblastine, and dacarbazine. What tests should be done?
So with doxorubicin, you want to do. Actually, I was reading about, or I got tested about this to yesterday or something. And so you could do an echo, but you could also do the nuclear study, which is actually more specific than
Mm-hmm.
the echo. And then with bleomycin, then you want to get like PFTs.
Very nice. Yeah. So that nuclear study, I believe, is a MUGA, MUGA is what
Yeah,
that's
that's the
called.
one. It's the Muga.
Yep. You get the MUGA scan. That's actually the most specific. But a lot of times you'll get an echo, a baseline echo, and then baseline PFTs to monitor for change. Um, so very good to know. And also, kind of here's a little nice little oncology thing. So doxorubicin, obviously we have cardiac toxicity. What medication do you give to try to decrease that toxicity? What do you give along with it?
I have no clue.
Yes, this is that dexrazoxane. It's kind of a, I believe it's like a radical scavenger that can kind of decrease the toxicity of doxorubicin. So kind of something. It's more for step one, I think, but good to know.
Big
And
hemonc
then
guy, huh?
Hemon guy, I like it. I like it a lot. So they also decide to do radiation to the chest because he has this bulky mediastinal lymphadenopathy seen on his CT. What complications do you expect from radiation to the chest on these exams? What do they like to test?
So you can get constrictive pericarditis. You can get radiation fibrosis too of the
Mm-hmm.
lung. Um, and then secondary malignancy due to both chemo and radiation.
Perfect. Yeah. So constrictive pericarditis is a very common setup for it with a patient with Hodgkin's disease ends up getting radiation to the chest and then secondary malignancies as well. You mentioned the radiation-induced lung injury can also happen. So good to know those things. That's just a good setup for them to test side effects of radiation. So now, as you can kind of tell, we've kind of gotten our way into the oncology section of this. So, 80-year-old male presents to the ED with signs and symptoms of pneumonia. Per the patient, he's also had multiple swollen glands in his neck and his axillae. Chart review reveals 20 pounds of weight loss in the past year. He reports feeling extra fatigued lately. On exam, his spleen is palpable. His labs are largely unremarkable, though. What's your next best step in diagnosis? And what do you think
Yeah,
is going
his
on?
so his spleen is palpable.
Mm-hmm.
Um, 80-year-old gentleman, so probably CLL in this demographic. So could consider probably get a CBC. We'll probably see significant leukocytosis, and then you would get flow cytometry to see if there's a clonal population.
Very good. So yeah, we would obviously in this case that I made it so the CBC is unremarkable, like the labs are largely unremarkable. But you're going to do flow cytometry specifically looking for B cell markers. So you have the CD5, 1920. CLL should be thought of when we have a very elderly individual, so in this case, 80 years old, and splenomegaly, as well as more of a kind of an indolent course. So maybe this is kind of chronic, 20 pounds of weight loss in the past year, and now he's starting to feel this fatigue. Labs don't necessarily have to be jumping off the screen as far as leukemia goes. Like it doesn't have to be super, super, super high white count. That doesn't necessarily have to happen. You're also going to get a blood smear in this patient. What would you see?
Would these be the smudge cells?
Perfect. So you're going to have smudge cells. They're going to be like these purple, squished out, they're going to be leukocytes. I encourage you to look up a picture. I don't have one in the slides. I should probably add one at some point. But yeah, smudge cells in CLL, very high yield. And then, so how do we treat a patient? Let's say if they were pretty much asymptomatic versus someone who is symptomatic.
So I think the big thing for CLL is usually monitoring, but also watch for is it the Richter transformation or is that more the CML? But but I believe it can have malignant transformation as well. So
Yeah.
observation as well.
So we're gonna observe. We're gonna watch full waiting. You can do targeted therapy if they're super duper symptomatic, but otherwise we're just gonna support them. I believe the Richter transformation is with lymphoma, if I remember correctly. That's with like follicular lymphoma to like diffuse large cell lymphoma, like an indolent to. But I could be
Yeah,
wrong.
yeah.
I'll have to look that up and research that a little bit more because I remember hearing about it. Um, so we're going to kind of go into kind of a good contrasting case, a 50-year-old female, diffuse lymphadenopathy, unintentional weight loss, progressive fatigue. A CBC is done and it shows a white blood cell count of 35,000, has eosinophilia on the differential, and then hemoglobin 9.6, platelets 250,000. So what's your likely diagnosis in this middle-aged woman?
So this would be the CML. Also, I just looked it up. Richter transformation is when CLL
Hmm.
transforms to a lymphoma.
Well, very good. Look at Mike. There's it's never too late to go into hemonc. It's never too late.
I'm washed up, man.
Obviously not, bro. That was good. So yeah, in this case, you were getting to it. I think you were getting to it. Um, middle aged, has eosinophilia, and now kind of more drastically changed labs, diffuse lymphadenopathy. This is CML. So, how do we confirm a diagnosis of CML? What do we do?
This would also be a bone marrow biopsy.
Perfect. And what would we expect the cytogenetics to show in CML?
Is this the 922? Is this which is this the Philadelphia chromosome?
Absolutely. So this is our Philly chromosome with the translocation of chromosome 9 to 22. And then obviously that's done with bone marrow and then cytogenetics on that testing. This is something very, very high yield with CML. What's our expected LAP level or our leukocyte alkaline phosphatase level?
This is low, and basically what that means is like whenever you have leukocytosis, you wonder if it's well, you can get leukocytosis as an expected physiologic response to like infection or something like that. So that's when you have a high LAP.
Perfect. Yeah. The way I've always thought about it is like the LAP is a way of kind of seeing, are these leukocytes properly functioning or being put in the right, situation. So in this case, it'd be low because these leukocytes have stuff wrong with them, as opposed to in a leukemoid reaction where you have a super, super duper high white count in the setting of an acute stressor like an infection. Those leukocytes are very functional, so the lap level will be high. How do we treat CML? How do we specifically treat CML?
Oh, this is that tyrosine kinase inhibitor because you're treating the 922 translocation, which is BCR to ABLA. I remember there's an Anki card where it has like the audio, and every time you do it, it just says ABLA,
I don't think I've never heard it said like that, but yeah.
ABLA,
So specifically,
ABL.
you're going to give the
Okay,
medication
so it's
imatinib,
imatinib.
Gleevec, or Gleevec is the brand name for that. So that's a tyrosine kinase specifically targeted at the BCR ABL. It's the I forget what they call it, but it's when that two those two parts come together and they end up forming kind of a mutant kinase. I forget what it's called. But yes, it's specifically targeted against the BCR-ABL tyrosine kinase that is caused by the T9 to 22 translocation. And this was a really big breakthrough for the treatment of CML. And since then, now there are more medications like imatinib with the similar target, but having this targeted therapy really did change the management of this disease. So very high yield to know. Really look out for that eosinophilia, and I believe you can also have basophilia in CML as well on the differential. That is really going to be the way that they clue you into this diagnosis. So, a 60-year-old male recently diagnosed with AML undergoes induction therapy or chemotherapy right at the beginning. After his treatment, he is monitored. He begins to be lethargic with associated muscle cramping and runs a VTAC on telemetry. What's your diagnosis? And obviously, here I forgot to put in the um, animation, so that's too bad. But this is tumor lysis syndrome, one of our oncologic emergencies. So, what kind of labs do we expect? The big ones to know is hyperkalemia, hyperphosphatemia, hypocalcemia, and then hyperuricemia. I would say the big ones are hyperkalemia and hyperuricemia, but knowing these two are also very important. How do we prevent it? The most important thing we can do is prehydrate these patients with fluids, plus or minus allopurinol to decrease the production of uric acid. If they have an AKI in tumor lysis syndrome, you're going to see the crystalline nephropathy. due to the uric acid production. So that can cause tubular obstruction and therefore cause the AKI. So good to have an idea of tumor lysis syndrome. Preventing it with IV fluids is very high yield. Usually you're going to see this in the setting of an acute leukemia where you're going to have a ton of cells lysing once you give that therapy. So that's very good to know. So quickly moving into the next case, we have a 65-year-old male. He's in the ED with a 5-day history of worsening fatigue and malaise, associated dark urine. Initial labs are significant for a white blood cell count of 56,000, platelets 30,000, hemoglobin of 7.2. His LDH is high, haptoglobin's low. He has elevated PT and APTT. Blood smears done shows blasts with MPO positive, needle-shaped intracellular inclusions. What's your most likely diagnosis?
Are those hour rods? For so that would be consistent with like APML, which is acute promyelocytic leukemia.
Perfect. Yeah. So let's see if we have animations on this next one. We do, it looks like. So this is APML or subtype of AML. So the peripheral blood smear finding, you already mentioned it. These are going to be the hour rods, very high yield to be able to pick these out on exams. What's the translocation associated with APML?
This is the chromosome 15 with 17, and then it affects the RAR, which is like the retinoic acid receptor.
Very nice. That is absolutely correct. So you're going to have the mutant ryanodine receptor. And then how do we treat these patients?
So it's all pro retinoic acid, or is it all trans retinoic acid? But
All trans
essentially, it's
retinoic
vitamin
acid.
A, and it leads to it. You basically differentiate the blast cells and make them mature into mature leukocytes.
Perfect. Yeah. So very good to know that ATRA is a specific treatment for this. Basically, with that mutant ryanodine receptor, which is also like a retinoic acid receptor, uh, giving the all trans retinoic acid, therefore, kind of pushes these cells to differentiate like they were supposed to. Right then, right now they're stuck in the promyelocyte phase, and so you get the proliferation of those. So, kind of, I don't have it on the slides, I don't believe, but it's actually very high yield to know what complication could be associated with APML due to the presence of these MPO positive hour rods.
It's DIC, right?
Yeah, so you can have a DIC picture. As you can see with these labs, you can have like kind of a pseudo DIC. Like it's not acutely DIC, it can be acute, but in this case, you can just see the labs that are kind of looking DIC-ish, and that's because of these the MPO positive. The hour rods are actually kind of like pro-thrombogenic, so you kind of activate everything and cause that DIC-like picture. So we're kind of coming up to the last few cases here. So let's finish strong. We have a 64-year-old male, history of CAD, status post PCI. He's transported to the ED after an MVC where he sustained several injuries. Due to hypotension and initial hemoglobin of 7.2 with signs of active external bleeding, he's transfused with a massive transfusion protocol. We use that 1-to-1-to-1 ratio with a total of 3 units of packed red blood cells given. His bleeding stabilizes. His vitals are stabilized within 6 hours of arrival. However, he then notices leg swelling and has shortness of breath requiring up to 4 liters of oxygen via nasal cannula. A stat chest x-ray shows signs of pulmonary venous congestion and diffuse infiltrates. So what diagnosis are you thinking here, Mike? This is kind of our transfusion section of the review.
Is this the taco, the circulatory overload, essentially due to the massive amount of transfusions he received?
Perfect. Yep, absolutely. So the pathophysiology of taco, transfusion-associated circulatory overload, is just that. It's fluid overload. So it's going to look very much like heart failure. You're going to have pulmonary venous congestion and you have leg edema and all this stuff. And usually what they'll give you is large volume transfusion. So whether that is actually massive transfusion protocol or just a lot of units of packed red blood cells and stuff like that. So what do we do? So we have this patient, they're in respiratory distress, they have pulmonary edema. What do we treat it with?
Some diuresis.
Perfect. Yep. So we're just going to treat it exactly how we would treat that heart failure exacerbation with diuretics. So be able to pick out TACO on an exam with the clinical fluid overload syndrome. And then we're going to contrast it here. We have a 55-year-old female, history of alcoholic cirrhosis and COPD. She's in the ED after being found to be anemic to 8.9 at her PCP's office. This is an acute change over the last few days, and the patient reports dark stool with associated fatigue, occasional shortness of breath, GI is consulted for suspected upper GI bleed, and the FFP is given in the setting of coagulopathy due to underlying liver disease. 2 hours later, the patient is hypoxic, tachypnic, and hypotensive. A stat chest x-ray shows diffuse interstitial infiltration. Now, what's your most likely diagnosis?
He really didn't get that much, or she didn't really get that much fluids. So maybe trolley, the lung injury itself from the immune action.
Perfect. Yeah. So trolley, and the reason why, things to look at with trolley, number one, she didn't get that much volume, like Mike was saying. And now this is kind of bordering on an ARDS-like presentation. So diffuse interstitial infiltration, if they show you kind of white out lungs. She's hypoxic, tachypnic, hypotensive, rather than someone with like fluid overload where there's like signs of edema and they might be hypertensive. I would say if they're hypotensive, they're really trying to get you into trolley or transfusion-associated lung injury. Pathophysiology, Mike already kind of mentioned this. This is primed neutrophils in the lung endothelium. They're activated by substances found in the transfusion. So you get this presentation, like I mentioned, very similar to ARDS with that characteristic non-cardiogenic pulmonary edema. How do we treat this?
This would be more like supportive care, so especially, mostly like respiratory support.
Perfect. Yep. So we're going to support them aggressively, whether they need respiratory support, fluids, pressors, whatever they need. We're going to try to give it to them to get them through this kind of acute reaction, this associated lung injury. So actually, our last case of the slides here, and it's one of my favorite pathologies to kind of study and look at because of the findings and how kind of it presents on exams, just kind of interesting to me. So we have a 72-year-old male, and he presents to the clinic with the chief complaint of back pain. He reports that he's been progressively worsening over the recent months. He's also struggled with constipation during this time. On exam, you feel that he has midline spinal tenderness to palpation, and he has some mild to moderate peripheral edema. Initial labs are significant for a calcium that's high at 11.7. He's anemic at 9.7, and a creatinine that's elevated from baseline at 1.6. What's your likely diagnosis in this patient?
So it seems like he has quite a few of the crab symptoms. So he has the hypercalcemia, renal disease with a creatinine elevation, anemia, and then the back pain. So probably some bone mets. So multiple myeloma.
Absolutely. One of my favorites there. So multiple myeloma, the typical symptoms with those crab findings. So hypercalcemia, renal disease, anemia, and lytic bone lesions. What would we expect to find on the UA?
On UA, you could get uh, like proteinuria.
Absolutely. So you can actually get a nephrotic syndrome from this. And as you can see, he's got some moderate peripheral edema. That would kind of be what we'd suspect is leading to that. What would you see on the blood smear?
Oh, this is when the red blood cells kind of stack up together and form the rouleau.
Perfect. Yeah. So rouleau formation, the stack of pennies or whatever you want to call it. And then how about your best initial diagnostic test? So if you're starting to suspect myeloma based on your clinical findings, what do you go for first?
Normally you would start with the SPEP testing. So you'd want to look for a kind of a monoclonal spike.
Perfect. So you're going to look for an M spike on the SPEP. Also, you can kind of see sometimes with those labs, these patients can have a protein gap, which means their total protein is very high, but their albumin is within normal limits. So you're like, what is making up that extra gap in between those two values? And that's the intense amount of immunoglobulins that these patients are making, because that also goes into the total protein measurement. So now let's say you are very suspicious based on the SPEP. How do you confirm your diagnosis of multiple myeloma?
This would be with the bone marrow biopsy,
Good. And what kinds of cells would you see proliferating in the bone marrow?
plasma cells.
Perfect. So you have bone marrow biopsy showing clusters of plasma cells. What is the leading cause of death in multiple myeloma patients?
I, I think this one's also infection.
Yeah, and the way I've always thought about this is these plasma cells are making a ton of antibodies, but they're not very functional or different. Obviously, they're monoclonal, so they're not very diverse in their ability to defend against pathogens. So these patients are at increased risk for severe infection because of that. So good to know myeloma, both the symptoms and then kind of the associated findings. It's a good way to test nephrotic syndrome. Specifically, actually, it can be associated with the finding like Bence-Jones protein, which is like the specific way to kind of that they like to describe the protein in the urine that leads to kind of some tubular obstruction and therefore the AKI. Showing the cluster of plasma cells on bone marrow biopsy is also very high yield. You can also kind of get a similar presentation with a plasmacytoma, which is just where this is like a solitary plasma cell malignancy that can cause this. And then also just being able to differentiate this with all these symptoms from something like MGUS, where it's a monoclonal gammopathy of undetermined significance, where they're largely asymptomatic. And then the other one that they like to go after a lot is Waldenstrom's macroglobulinemia, where you're going to have IgM accumulation and more symptoms of hyperviscosity. So things like maybe vision deficits. You can also have like stroke symptoms from hyperviscosity, thrombosis, all of those things. So I didn't go into more of those things just because didn't quite have the time, but multiple myeloma is definitely the highest yield of that group of disorders. So thank you guys for watching. We appreciate it. Like I said, if you have any questions about our question format going forward, and then if you have any questions about cooking for Mike or animals in nature for Xander, our email there is below. So thanks for watching, guys.